I want to move on now to transplant-eligible patients, the younger population, and we're just, for the sake, just to get it over with, I think we'll all agree that this is not an age-dependent phenomenon. It's at least up to the age of 75 or so, it's more to do with physical performance status. So that said, let's take that and let's do the same thing. Let's ask each of you to say what you do today and what you'd like to do maybe if insurance wasn't a barrier. So Jatin, what do you do today for the younger transplant-eligible patient induction therapy?
Yeah, great question. So I think there's a couple of key principles here. One, the depth of response matters. And so I think that the deeper the response going into the transplant, the better these patients do, the better product you collect. And so I think that's important. And number two, I think that we're going to be giving short course of therapy. And so the goal is in a short time frame to get the best response we can. So for us, we'll use a 3-drug combination off protocol with either VRD or carfilzomib Revdex. But I think more importantly, we have a clinical trial now with going to 4 drugs, as Paul mentioned earlier. And so we have a nice trial with RVD plus panobinostat. So looking at incorporating HDAC inhibitors, earlier lines of therapy. And
so we'll stay away from clinical trials a bit because people can't access them all that often, but you would use RVD or KRD, and we'll ask you why you would use one or the other in a minute. But you think the future is histone deacetylase inhibitors in combination or others?
So I think we're going to go to 4-drug combinations in the future. I think there's certainly going to be a role for HDAC inhibitors based on our initial experience about how well tolerated they are in combination, and the depth of responses that we're seeing is amazing.
I'm going to ask Paul this. I think I'm dying to know the answer. KRD or VRD, if you had your choice?
I think one size does certainly not fit all, and I think that I would tailor. I think that I'm very impressed that KRD is very active. I do think, however, there's this rare but real issue of some of the vascular toxicity that comes with it, and I think we need to better understand who's going to be affected by it and why, and fence them off to some extent. But having said that, I'm very impressed by how deep and pronounced and prolonged the responses are. And, you know, again, in discussions with people who've led in this field in the upfront setting, such as Andres Jakubowiak, you know, I'm struck by the durability of responses that he's reporting. Although, as I participate in a clinical trial with him, I realize the patients are very carefully selected, and I think one has to be careful about extrapolating from early phase 2 data. I'm very impressed by the work being led by actually Shaji Kumar in the ECOG group, comparing KRD to RVD, and I can share, as you know, we all participate in the group trials, you know, there have been some surprising toxicity signals from that trial that surprisingly have been against KRD. So I think we have to be careful. Having said that, I think a proteasome inhibitor IMiD platform for induction, to Jatin's point, is clearly established. I think what's really interesting, Keith, as we go forward, is the field is moving so fast. I mean, as Sagar said, the monoclonal antibodies are going to be in this space very soon, already are. And I think that's going to, again, make us have to rethink what we do in the transplant-eligible population.
I would just add that yet again, it doesn't have to be either or. You can start with RVD because it's the convenience of the sub-Q bortezomib and not having to come 2 days back to back is great. And if somebody does not have a dramatic response, let's say you aren't even getting a VGPR or PR, you could switch after 1 or 2 cycles to KRD. It doesn't have to be an either or offside of a clinical trial.
But all things being equal, and patient walked in tomorrow, what do you use?
I would say, you know, because I think for the vast majority RVD, but if somebody has very high risk or aggressive disease, I would start with KRD.
Okay, so that's an interesting concept. You would choose the carfilzomib option for a high-risk patient, and why would that be?
I think we're accumulating data from several studies that when you compare head-to-head CAR with bortezomib, particularly, not dose does matter as well, but I think that CAR has a more potent activity, both preclinically as well as clinically.
So if you're supposed to use your best therapies up front, though, why would you limit the KRD if you think that's better for high risk?
Well, I think 2 things. One is, again, sometimes cost can be an issue, particularly for the practicing community doctor. We have used it in academic centers, and I think we get away with a lot more, but for the community practicing doctor, that's an important consideration. And the second thing is, if you have a VGPR after 1 cycle with RVD, do you really need the KRD? And to the point of, I agree that
it depends if you want neuropathy or not, I think.
But I think the rates of neuropathy with subcutaneous bortezomib are low. And to Paul's point, while the rates of, there's definitely some cardiopulmonary signal, it's not very high, but it's hard to predict who's going to get it.
Right.
But we also have to remain very mindful that all the carfilzomib studies are very selected populations. Sure. And that may not be what's happening in the community.
Sagar? Did you already go? No.
No.
You published the definitive so far until this randomized trial, VRD with transplant.
I mean, I think VRD is easy, it's convenient. I think if you're going to talk about potency issues, you're going to 56 milligrams per meter squared of carfilzomib, which is not the dose we use with KRD up front. So I think RVD is the current standard, and the ECOG trial will tell us whether that's right or wrong.
So I think if I may, one just an additional point, Keith, I think there is a point for community oncologists. Just be a little bit careful. In my experience now, because I've used it as part of clinical trials too, KRD upfront in renal dysfunction. That's one thing that I think is worth sharing with community docs, because whilst I don't think in any way carfilzomib is nephrotoxic, I've definitely seen an interaction in patients who've had some degree of renal dysfunction. And correct me if I'm wrong, but the trials were careful to exclude patients with significant renal disease.
To that point, it may be worth also reminding people that the hydration pre and post does not need to be continued indefinitely. If the patient tolerates cycle 1 really.
I'm sort of taken by the tone of the group here that VRD remains the standard, but I'll tell you, I've been in other groups in the last few weeks where asked to vote, the whole room of myeloma doctors have said KRD would be their choice. So I'm just coming back to that and saying this seems a little bit discrepant with what I'm hearing here today.
So, I mean, I think that on a trial, as I mentioned, there's going to be some other options as we go down the road, but I think that there's still a role for KRD. And so in our practice, there's, I think, a mix between VRD and KRD up front.
I mean, the reason, personally, I would use KRD if I had the choice, but it's sometimes insurance coverage concerns. We've gone with VRD. And often, frankly, as an academic centre, the patients come to us already on VRD. But what about depth of response? Does everybody agree that that's important? We need deep responses before transplant?
So I think you want to give the treatment that has the highest likelihood of achieving a deep response, but if you don't get the deep response, I don't think you should change therapy. Presuming you achieve a PR.
I think everybody's in agreement with that. Is everybody transplanting every patient?
I would actually emphasize that point again, because I think that sometimes that gets lost where people want to continue on till CR in the community, and that happens quite frequently actually. So I think we take that as a given, but I think actually that's important to re-emphasize that if you just got to a PR, you don't need to go for 10 more cycles to try and drive towards a CR. If you're going to go for transplant, go for transplant.
And one of the reasons for that is sometimes it gets a little hard to collect stem cells if you take too much lenalidomide or...
You just have more toxicity at that point in time, and so.
I think different groups have different approaches to this, though, because I will share with you that certainly based on our data from the IFM-DFCI collaboration, the quality of response prior to transplant really does predict for who's going to do what when. But I take your point, Jatin. You have a dynamic of response. To your question, Keith, do we transplant everyone? No. We do not. Obviously, our randomized trial remains our top priority for good reason, I think. At the end of the day, we firmly remain of the view within our centre that, again, one size does not fit all, and that the younger patients clearly overall benefit from transplant as an option. The issue of timing is a great and important issue that obviously we're addressing in our randomized trial, but at the same time, I'm struck that there's a subgroup of patients who we may not benefit from high-dose alkylation. There is the majority who probably are, but there is a subgroup in who we may do less. And I think we need to better understand who they are. Hopefully our prospective trials will dissect those people.
And
maybe you could speak to since you're the lead of the study, what do you think of the IFM data that are coming out?
That's exactly what I was going to ask.
Yeah, well, I think they're very helpful.
Can you first explain it to our audience?
Of course. Well, what this is it's two parallel studies, and the US trial is the so-called determination study, CTN 1304, and it's now Alliance endorsed, so it's a true intergroup study. And in this regard, the trial looks at RVD, followed by stem cell collection after high-dose cyclophosphamide and GCSF, and then patients either are assigned to early transplantation, followed by RVD consolidation, and then R maintenance continuously on the US trial, or if they're randomized to the transplant-delayed group, essentially they keep transplant in reserve. They get a further 5 cycles of RVD, R maintenance, and then at first sign of progression gets salvaged and then transplanted. So it's really early versus late transplant.
So Paul, the French are reporting at this meeting, the French International French Myeloma Group are reporting that with their version of the same trial, which The only difference is really that lenalidomide only goes for 1 year.
Right.
A major benefit in progression-free survival to transplant. So how do you react to that?
I would rate very favorably in the following. You say the only difference is lenalidomide maintenance for 1 year. I think that's enormous. And I think the important point to note from the French data is the following. The progression-free survival benefit is 8 months. There is no survival benefit.
Yeah.
Arm A versus Arm B. No, Arm A currently is 83% survival at 4 years. Arm B is 80%. That's the transplant arm. Now, you're right, it's not yet, but the continuous therapy may be vital to that equation.
That's a good point.
And I think the point is that if you look, and I've spoken, obviously we work very closely with our French partners, what I'm hearing, although the data is not there yet in terms of the aggregate of the trial, is the events start when the lenalidomide stops. And interestingly, in our trial, we don't have enough events, which I think is really interesting. Now, obviously, we're behind in terms of enrollment, but we're almost there. We're at 540, actually, with another 120 to go. Once we've accrued, I think we'll be able to really inform our physician
in a way,
colleagues
the
and
difference
patients
between the
accordingly.
French and American study
Yeah.
it kind of approximates the first study. Do you
Yes.
do RD18 and stop, or do you do
Excellent
RD to
point.
progression? And we
Excellent
know
point.
the answer to that. You treat to progression led to imperial.
So that actually is